This is Dr. Andrew Young at St. John's in Santa Monica, and we're going to take a few moments and talk about one of the difficult challenges in knee replacement, specifically replacing a post-traumatic knee after a prior ACL repair. Now, this turns out to be one of the most difficult operations because there's often ligamentous, sometimes multi-ligamentous injury, there's post-traumatic scarring, there's deformity, and there's also the problem of hardware used to fix the ACL graft. So of all those topics, we're just going to take a deep dive in how we manage hardware removal using the robotic system. Okay, so we'll start with the most common type of post-traumatic arthritis that we see after an ACL repair. So we see a lot of arthritic change. There's loss of joint space, there's irregularity in the medial femoral condyle, there's subluxation or shifting of the tibia. But very importantly, this patient with a prior ACL has an interference screw in the femur and in the tibia. And this is the position when we're looking at the knee from the front. This is the position when we're looking at the knee from the side. So this tibial screw is what we call anterior medial. Anterior medial. This screw is what we call posterior lateral, because these screws are in a three-dimensional position within the bone. So we need to know how we're going to approach the knee replacement, and specifically the position of these screws in relation to an implant that we hope to place. I'll show you how we do that. So the beauty of the robotic system is that we're able to make a CT model of the knee prior to surgery. So all this planning is done on the front end. And this specific example, we're looking at three different planes or three different views of the femur: from the front, along the length of the bone, or what we call axial, and from the side, or sagittal. And we're going to look at the view in 3 dimensions because, of course, this is in a 3-dimensional position. And we're going to see how our implant, which is green, fits in relation to this screw. And from this, we can see in all 3 planes, even though this screw is in the distal femur, it is nowhere near our implant. And so this screw does not need to be removed. And that's important because every time we take out a screw, we have to take out all the bone surrounding the screw. This screw is buried within bone. So if this screw is not in the way, that means we can save all this bone. Let's look at the tibia. Now, the tibial interference screw here is in a very different position as relates to the knee replacement compared to the femur. We saw in the femur, this pin is out of the way of the implant. However, this screw impinges directly with the implant. So even though this screw is buried within bone, it will need to come out, or it will block the placement of this implant. And we need to know this ahead of time. So we know we have to go over this one. We have to go after this one. This one we'll leave alone. So this is what our completed knee replacement looks like. And the nice thing is we know exactly what our knee replacement will look like afterwards because we planned it ahead of time. And so our radiograph matches exactly our preoperative planning. But very importantly, we also see that this screw was never in the way of the implant. And we knew that ahead of time by looking at the CT. On the other hand, when we looked at the tibia, we saw that this interference screw was blocking our tibial implant. So this had to be removed. And at the end, we can see our knee replacement looks exactly as we had planned. We resolved the arthritis. There's a nice space in between the bones. And we restored the architecture where the femur and tibia are aligned. This femoral screw was never in the way. We left it alone. The tibial screw was in the way, had to be removed, and so we removed it. Let's take a look at another example of fixation. Okay, here we have another arthritic knee, bone on bone, subluxation, flattening of the condyle, but very importantly, prior ACL repair. Now, this is a slightly different method of fixation. There's still an interference screw in the femoral bone tunnel, but here we see a staple used to secure the graft. Okay, so the first thing that we're going to do is make a 3-dimensional model to see what is in the way and what needs to be removed. Let's take a look. So once again, the CT images are invaluable. You can see there's such an extensive amount of deformity around this knee. These are osteophytes, bone spurs everywhere, which are distorting the natural anatomy of the knee. So one benefit is that we can actually see what the implant will look by visually removing the deformity around the knee. But the second thing that we'll do is we'll actually look at the position of the hardware, the screw and the staple in relation to the implants. So this is what it looks like statically, but I'm going to show you what it looks like dynamically as we move the knee through different sequences. Okay, so we're going to show you how we use the computer to find the screws. So this is the femur, and then this is the tibia. So let's look at the femur screw in relation to the femoral implant. So this is the femoral implant, and we can see that screw is very far away from the green implant. Then we'll check it in the axial plane and see the screw. We can see this is the front of the implant, this is the back of the implant. That screw is not in the way. And then we look at from the side, wide open. And you see that screw is not in the way. Now that's very helpful information to us because that's an interference screw. It's completely buried within the surface of the bone. You can see it's not even visible. So all this bone would have to be taken out to find that screw if that screw were in the way. On the other hand, if we look at the tibia now, we're dealing with a different picture. So here's the tibia, here's the keel for the tibia, here is a staple coming in from the side. And we can see that staple hits right there at the keel. And then when we look axially, we look down the bone, I can see right there. So this staple will have to come out because it's blocking the implant. Okay, so intraoperatively, this is what that screw looks like. It's in the lower portion of the incision where the patient had the prior ACL reconstruction. So now that we know that it's in the way, we know that we have to go down to this level and uncover the soft tissue and identify this screw. And then we'll use specific tools specifically to remove this staple. And this is what the staple itself looks like. It pretty much looks like a staple. And so now here we are at the end of the surgery. Remember, we started with a screw here in the femur and a staple here that was blocking. We knew from our preoperative planning that all this was deformity, and we knew that this screw was not in the way. It was removed from our implant, but we also knew this staple immediately blocked it, so we removed it. Okay. All right, let's take a look at another example involving even more hardware. Okay, this is a pretty severe case of post-traumatic arthritis. So this patient has a lot more hardware because there was even more ligamentous disruption. So this patient has a history of an ACL injury. This staple and this cortical screw are used to fix the ACL graft. There are actually two staples here. It looks like one, but if you look from the side, you can see there are two staples. One staple is used to secure the bottom end of this ACL graft. And then the other staple, these two staples are used to secure an MCL or medial collateral ligament disruption. So this patient had an ACL tear fixed with this staple and this hardware, as well as an MCL disruption fixed with these two staples. So when we fix a knee, we want to preserve these MCL staples because this is what's giving stability to the medial column, as long as they're not in the way. These ACL staples, however, may be in the way. So we're going to get a CT again to find out if they conflict with potential hardware placement. Okay. So first we're going to look at these two staples. This staple, this screw, these are not in the way. They're nowhere close to the implant. But this is a very interesting. This one that goes on the inner column to staple the MCL, it becomes very close to this peg used to secure the femur. But we can see it actually goes right around it. You can see one tine of the staple. Remember what that staple looked like? And the other tine. So even though this is in the area, it is exactly in between. And because it's exactly in between, we don't have to remove it. And we can maintain the fixation along the medial collateral ligament. Because ahead of time, we know it will go exactly between the implant. And this is very powerful information to have in preserving medial collateral integrity. Let's look at the tibia. Okay, now when we look at the tibia, this is very interesting because these two staples are in different parts of the tibia. This is providing fixation to the ACL. This is providing fixation to the MCL. And when we look over here, this MCL staple is not in the way. It's close, but it actually doesn't block the implant. However, the ACL staple completely blocks the implant. So we know that this ACL staple has to be removed, but fortunately this MCL staple, which is providing stability to the medial collateral, doesn't need to be removed. And so we can see from our post-operative x-ray, we've restored the anatomy, we've corrected the arthritis, but very importantly, we saw this hardware that was in the higher portion of the femur was never in the way, didn't have to be removed. This staple went right in between the implant, didn't have to be removed. The ACL staple had to be removed, but this MCL, which is in this area, this staple, which is securing the MCL, could be maintained to give ligamentous support along the inner side of the knee. Okay, one last example. I can see you guys are getting the picture of how this works. I'm just going to show you another example of ACL fixation. This is a combined cortical screw, interference screw. So this is the tibial side, this is the tibial tunnel, this is the interference screw used to secure the graft, and this is the cortical screw used as an additional form of fixation. On the femoral side, there's also an interference screw with a stabilizing cortical screw. And then we'll go get the CT and look at the relationship between these screws in the femoral implant and these screws and the tibial implant. Okay, so when we look at a three-dimensional model, we can see that the femoral screws are superior or above the implant and posterior, so they're clearly not in the way. Okay, so even though it looks like there's a lot of hardware that could be blocking this femoral implant, we can see when we look at a CT reconstruction, it's not in the way. However, when we look at the tibia, we can see both of these pieces of hardware. Interference screw goes right through this potential tibial base plate, and this cortical screw is blocking the tip. So both of these will have to be removed. This will be maintained. Let's look at the post-operative x-ray. And so really, that's the nice thing about it. This preoperative planning is so important because it helps us understand what needs to be corrected and what should be preserved. So we can fix the knee, but also preserve as much bone and prior ligamentous support as possible. These two bottom screws and the tibia have been removed. The ones up top have been preserved. Okay, so converting a knee after a prior ACL repair that's developed traumatic arthritis into a total knee replacement is a far more difficult procedure than routine knee replacement. And in this video, we were just talking about how we dealt with the hardware and specifically how we leverage technology, CT scanning and three-dimensional modeling to help us understand what needs to be removed and what should be preserved. Removing hardware is a non-trivial task. Much of this hardware has been in for 15 to 20 years and buried under layers of bone. If the hardware needs to be removed, then we need to remove the hardware, no matter where it is. But if the hardware is not in the way, then it's much safer to preserve the bone and soft tissue and the integrity of the surrounding area. Thank you very much.